Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and this episode's going to be a little like the one I did a couple of months ago when I had the anesthesiologist, Dr. Michael Hewitt, in to do a podcast with me. He was in the operating room for a surgery that I had back on February 20th, which was to remove part of my colon due to diverticulitis. And finally roped the doctor that did it into the studio for this podcast. I remember, Doctor, the first time I kind of asked you about it, you didn't seem like you wanted to come in here and do this.
Not necessarily. Not necessarily. It's just, you know, just finding the time and getting in here.
Yep. Dr. Stephen Donahue is a colorectal surgeon here in Rapid City at Monument Health. So I get to sit down and ask not only about the condition that I experienced when surgery actually becomes necessary, and the Vinci robotic system that was used on it, what it does, and what it means for patients facing similar decisions. So first off, Doctor, thank you for coming in here and doing this. I know
happy to be here.
You do a lot of these, from what I understand. So, I mean, it's busy. Yeah, to get you roped into doing some of this it takes a minute.
Yeah.
Give me a little bit of your background first, Doctor. How did this whole journey for you begin? Did you know this is kind of what you wanted to do?
Not even in the slightest, which maybe I shouldn't admit. But no, I had always been interested in healthcare. Tinkered with the idea of going into physical therapy, occupational therapy, something along those lines. And then I met my lovely wife, and her dad was a physician, and he just said, you should take the MCAT. And so I did, and that's how I got into med school. And then my wife's brothers are all surgeons, and saw their lifestyle, thought about it, and now I love it.
Well,
fell in love with it in med school, so that's where I started.
That's a big difference from therapy to being a surgeon.
Yeah,
that's
this was like second year in college. I had no idea.
Right.
I had no idea what I wanted to do.
Yeah. But did you have any of this in your family? Is there any background?
Not in my family.
Not at all,
no, nobody. Yeah.
You get to be the first
business,
doctor.
My mom's a teacher. Yeah. Trust me, it's great being the only doctor in the family. Hey, what about this? I was like,
I'm sure.
Mom, I'm a colon and rectal surgeon. I don't know what to tell you.
I don't know what that spot means.
Yeah.
I'm sorry. Well, let's talk a little bit about, for someone who's never heard the term, how would you explain diverticulitis in just like simple terms?
Yeah. Diverticulitis and diverticulosis are the same process. The diverticulosis is the simple presence of having these little pockets. I usually call them pockets when I'm talking to patients. Pockets are outpouchings, weaknesses in the colon wall. They all kind of mean the same thing. What it is essentially is a ballooning of the colon wall that causes a weakness in that area. And then once you have them, you find them on colonoscopies all the time. People's colons are kind of littered with these little pockets and outpouchings. And then for whatever reason, though they can get plugged or blocked, swollen, inflamed, and then the pocket itself is kind of blocked off from the rest of the colon, and that's when you start to run into issues where maybe you get a little perforation right there, a little bacteria kind of seeps out through a micro hole, and then you get diverticulitis, which is inflammation.
So why are we getting these so much? It seems like your colon has a pretty specific job, right?
Yes.
And it seems like it's a pretty easy job, honestly.
Yeah, the colon's main job is to absorb water. The small intestine absorbs almost all of the nutrients, and so the colon doesn't even do a whole ton of nutrient absorption. It's just to essentially gather the water after the small intestine has done its job. And so, yeah, you're right. It's not the brightest organ in the world, but in terms of why we're getting diverticulitis, a lot of it's theories. Some component of genetics, some component of diet, obesity, Midwestern diet, low fiber. Fiber is really healthy for the colon, and we don't get a ton. The recommendation is 25, 35 grams a day of fiber, and if you look in the food packets of what you're eating, you'll get 2-3 grams of fiber per serving of whatever it is, and so low fiber diet has a lot to play into it. But some of it's genetics, some of it's diet, some of it's obesity, some of it's bad luck. And then once you have the diverticulosis, the outpouchings, Then again, it's a theory of what causes diverticulitis to happen. There was an old adage of you eat a nut, a seed, a popcorn kernel, and they get stuck in the little diverticulosis, the outpouchings, and then that causes diverticulitis. Maybe that's still happening, but it's kind of been debunked actually. And so we don't 100% know why it is all happening. There are a lot of theories, but
I didn't have a strawberry for 20 years after I was diagnosed with it, because that was one of the very first things back in 2003.
And we still tell people that because we don't know what to say, and it's easy to say, okay, don't eat nuts, don't eat fruits with like strawberries with the little seeds in there, because in theory they can, and I don't know if it's true or false, but
okay. Well, what are you mentioned the Midwestern diet a couple of times. It seems like out here we would have higher fiber diets just because of the vegetables alone. But I suppose it's a high meat driven diet.
It is
not
meat and potatoes, and then there's a lot of there's different types of fibers too. Actually, soluble fiber, insoluble fiber. You have to get a combination of both. Certain ones will affect the colon in different ways. Anyone that comes to my office that has constipation or other issues, I just recommend they take a fiber supplement, just because nobody gets enough. And I do the same thing to myself too. You just take a fiber supplement, Metamucil, and then you cover your bases for the entire day. You don't have to worry about it.
So what are warning signs then that tell someone that this isn't just a stomachache? I mean, from my own experience, I can tell people the pain is unbelievable when you have a flare-up. Right. But what are warning signs for people that may be like, well, wait a minute, maybe that isn't just a...
And that's how it goes for a lot of people too, is diverticulitis is a spectrum. And so it can be anywhere from, like you're saying, I have a little twinge of pain on my left side, and who knows what it is. Is it gut ache? Did I eat something bad? Am I constipated? It could be a very mild diverticulitis flare. But then it can range anywhere from that all the way to, I have a free bone perforation, there's stool in the abdomen, you're going in, you're septic and sick, and you need emergency surgery, colostomy bag. So people usually lie somewhere in between there. And a real not a real diverticulitis flare, but a more severe one is not very subtle. It's severe pain. This is not just a routine stomach ache. Fevers, chills, sometimes blood in the stool, or sometimes you can't poop. When the colon gets swollen and inflamed and the wall is thick, then it can block the stool coming through, and you can get really severe constipation right around the time of a flare. Or sometimes it's even the opposite. The colon will spasm, and then you get severe diarrhea. And so severe pain, diarrhea, left-sided pain usually in the presence of diverticulosis.
Where else can it happen? Where else?
Well, it can happen anywhere in the colon. It can happen anywhere in the colon.
Oh, okay.
The sigmoid colon, which is where you had yours, is the most common location because it's got the highest pressure. Well, that's not necessarily true. The cecum does, but for whatever reason, it's almost always in the sigmoid colon where people get diverticulitis. But you can have it anywhere.
Anywhere in the
entire
colon?
Yeah.
Really? Okay.
Yeah.
How far? One thing that surprised me after my surgery was done, and I asked you, well, how much did you take out? I was expecting you to use your thumb and pointer finger.
Yes.
But you used both palms of your hands.
Yes.
On how much is taken out of there.
Usually, people always ask, about that much. Usually about 12 inches or so.
How much colon do you have?
You've got a couple of feet at least of colon. So starting, in most people's loops a little bit here and there, and so you've got a couple of feet, and I usually take out less than a quarter of the colon to do diverticulitis surgery. Yeah.
It is amazing because you said it's kind of accordion-like in there, correct?
Yes.
So you can kind of stretch that out a bit?
It a little bit.
Okay.
You can stretch it. It takes a couple of turns, and then it's always hard when you're making a decision. How far do I go? Even if it looks actively inflamed in one area, well, how far do I go on either side? I always go down to the rectum. That's standard to just go down to the rectum. So that end is easy. But how far proximal do you go? Because a lot of people will have diverticulosis through the whole colon, and we don't remove the entire thing. And so you have to make a decision on how far up you go. And so usually I end up going about that 12 inches or so until it starts to look pretty healthy towards the descending colon.
Well, by the time a patient gets referred to you then, what are you looking for to determine if surgery is the right path?
Yeah. Not everybody with diverticulitis needs surgery, and it's just a discussion now. We used to say, okay, you get 1 episode, you're fine. You get 2 episodes, maybe 3 episodes, yeah, it's time to consider doing surgery. But it's not like that anymore because everyone has different goals of what they want. Some people are really averse to having surgery. They don't want to undergo the risks, and so it's a discussion to be had. If you get a diverticulitis flare once every 5 years, this is just in theory, and then you go in, you get antibiotics, and maybe you spend a day or 2 in the hospital, and you're okay with that, then that's fine. I mean, the chance of people progressing to a full-blown perforation after they've had a mild flare is pretty low, but it can happen.
Okay.
That's the risk. And so then the other side of things is, well, do you travel a lot? Do you go overseas? Can you risk having a diverticulitis flare if you're a truck driver or things like that? They're all things to consider. But and those are for more mild flares. Someone that comes in who's had a perforation, an abscess, a drain placement, a fistula, obstruction, those are all pretty hard signs where, yeah, we should probably just do surgery to get it out.
Well, and that's in my case. I was first diagnosed in 2003, and I probably, for the first maybe 5 years, there was a flare-up once a year, maybe. Progressively started to get worse, where I was at least having 1 or 2 a year, probably, right? Got to a point where antibiotics generally took care of it, or just rest, just like a liquid diet for a few days kind of took care of it. And then back in December, for the first time in this whole 20-year run of having it, I ended up in the hospital for 11 total days, 5 at one time and then 6 in another. Well, that's counting the surgery that I had as well, I guess. And the concern for you, I believe, in my case was, because you had mentioned the fistula, where it had actually gone, I believe, from the colon and into the bladder, correct?
Yeah.
So that's obviously, if that's happening, you need to talk about surgery.
Yeah, so that's a colovesical fistula is the name of what you had, and it's not as common, but it certainly happens. We certainly see it, and because this repeated cycle of ongoing inflammation, abscess, irritation, the colon sits right on the bladder in the abdomen, and so it will start to irritate the bladder and erode through the wall of the bladder. And then once you get what's called a fistula, which, like you said, is a connection between the two, that usually doesn't go away until you have surgery. That, and you run into issues with frequent UTIs and bladder pain, bladder spasm, and people can even pass stool through their urine, which can be painful too. And
the first time my family doctor said that, I knew then, yep, I'm having surgery.
Yeah, you're like, yeah, let's not get to that point. That sounds terrible.
What I want to talk about mostly for this conversation too. A lot of people, I think, everything you just explained is very good to know when you experience pain like that. Absolutely get it checked out. Mm-hmm. Don't let it go too far.
Certainly.
Because, and you'll know, trust me, if you have a flare-up, it's unmistakable.
Yes.
But to get it fixed and to get that surgery, and we've done a couple of podcasts on the Vinci robotic system that you used for this surgery, which I was half excited to get into the room just to see it and then to know that this thing was going to happen. So for people who picture robotic surgery and, they imagine stuff, as a kid, I remember thinking, God, someday we're going to have this kind of thing. And we kind of do. It kind of is sci-fi almost with this machine in the room.
It almost looks like a sci-fi machine. It's got 4 big long arms with joints that move, and you're not anywhere near it when you're operating, which is bizarre. So this thing looks like it's moving on its own. But it's opened a lot of windows and not necessarily. I mean, we can do all of these surgeries without the robot. Mm-hmm. It just makes it easier. And there's been, at least in surgeons my age, a movement moving from laparoscopic surgery, which was the old minimally invasive operation, into robotic surgery. Some of the benefits of doing that are, the biggest one is the arms on the robot articulate, meaning they have a wrist. Mm-hmm. And so I can use a wrist to turn around corners, get deeper into the pelvis, bend up, look sideways, things like that, which is really hard laparoscopically. And then another benefit is control. So it always takes two people to operate, an assistant and a surgeon. And in laparoscopy, you're dependent very heavily on the assistant. They have to be operating two hands while you're operating two hands, and you have to be essentially one brain operating together in order to get everything to move in the proper way so that you can see or do what you need to do. And robotically, you can do it all yourself. So you get to control all four arms, including the camera, and you can manipulate them with your two hands. So you get to operate, twice as much, essentially.
Well, and when I went into the room, I remember looking at the robot and seeing it, asking a few questions before, Hewitt, who's very efficient, gets you out. I looked over and was surprised at how far away you actually sat from the machine and the patient there.
Yeah.
Is it? I mean, it's not weird to you now, but do you ever think, God dang, I'm pretty far away from this?
When you say it like that, it is weird. I mean,
Yeah.
we were talking about this earlier. The when you walk in the room, the robot's tucked away in a corner behind some drapes, and then we wheel that up to the bed. You're sitting on the operating room table after your sleep. We get everything all set up, myself and an assistant. We get the robotic trocars in place, then we dock the thing, and then I scrub out and leave. It's almost like you're essentially going into another room over there. Not really, but you're in the corner facing a wall away from the patient behind the anesthesia machine, and that's where you operate from. It's quite bizarre to think about it, and it's all Bluetooth. But when you get into the surgeon console and you put your eyes in the machine, there's microphones in both of your ears. You've got two eyeballs, and you're looking through the camera, and it's pretty cool.
Yeah. Well, it is. It's about as sci-fi as you can get right now. Until we're at a point where you're doing it from home.
Yeah. Right.
To just remote in at that point, right?
Yes.
I think one of the biggest advantages to having robotic surgery too, at least from my standpoint, again, I can talk about it because I had there was 5 incisions that the robot has, correct?
So
four
for the robot, 1 for my assistant to operate through, and then the bigger one is an extraction site.
Right, that's it. Yep. The most amazing thing about it, frankly, is the healing process afterwards. I was amazed at how quickly all of that healed up. Mm-hmm. Just within weeks, you're like, well, I mean, if you didn't see it, you wouldn't even know that that robot was inside of you.
Yeah, it is amazing, and people usually recover quite quickly, and that's one of the big benefits, too, of this is you get it out of the hospital a little bit faster, get on a diet a little bit faster. Recovery is a little bit easier because you don't have this big, huge incision from all the way from your pubis up to your sternum, essentially.
Is that how big it used to be?
It used to be. I mean, for some surgeries, it would be quite that big because if you're doing surgery on the colon and you have to mobilize the top half of the colon to bring it down to the rectum, then you're doing surgery on both ends of the body, of the abdomen. Yeah, so it was a big incision before. And so recovery is a lot easier. That and scar tissue is a lot less, too. God forbid you ever need surgery again, the scar tissue is going to be significantly less than if you had an open operation.
It is, and if you looked right now, you would, if you didn't know what you were looking for, you wouldn't see the robot scar specifically. The extraction scar obviously is bigger.
Sure.
That's probably, that will probably always be there, but still, even that seems tiny compared to the way things used to be.
And we usually try to tuck that one a little bit lower too. Mm-hmm. But yeah, a lot smaller than it used to be.
Right. If someone in the community right now listening to this podcast, is nervous about needing this kind of surgery, what would you want them to know before they even walked in to meet you?
Yeah, I mean, the questions people are always asking. Everyone always asking the same questions, and they're good questions. Mm-hmm. What is my bowel function going to be like after I have this surgery? Am I going to be incontinent? Am I going to, have 10 stools a day? That's pretty much the biggest one I think a lot of people want to know about. And the answer for this specific operation is you shouldn't notice a ton of change. Mm-hmm. You shouldn't notice a ton of change. I tell people if you have a stool once a day, maybe once every other day. Well, you might have 2 stools a day or 1 a day. It might move up slightly in frequency, but it shouldn't be a huge change. And that's a lot of people worry about that, and specifically incontinence. And this should not affect incontinence at all. There's a lot of risks to surgery, but again, it is overall very safe. We do a lot of these, and so most people do quite well.
Well, and one thing we didn't really talk about, which was my number one main concern going into this. I wasn't worried so much about the surgery. I wasn't worried about the outcome generally, because you were pretty confident in how you felt it was going to go. That colonoscopy bag.
Yep, everyone hates the bag.
Yeah, that's so. What determines whether or not you get that? I mean, I didn't have to have one.
Right, and the whole goal of doing elective diverticulitis surgery is to avoid a bag. And I tend to scare people when they come to my office and tell them it's always a risk. If you get colon surgery with me, I'm going to tell you there's a risk of getting a bag.
Right.
Okay? It's just I can't justifiably do surgery without saying, well, there's some chance you get a bag. But the whole goal and the whole thing we're trying to avoid here is having to do that, because I know everybody hates it. And we want to make people happy, and it requires a second surgery to fix. So yes, you're right. The determination comes from the extent of inflammation, the extent of diverticulitis, the extent of dissection we have to do, and the simple presence of having a fistula like you did doesn't mean you necessarily have to get a bag. Some people might think that if you do diverticulitis surgery and you have a fistula, you're getting a bag. But it's not necessarily that. After you've taken everything down, it all depends on how the 2 ends of colon look that you have. So you take out the segment, you've divided it both, and now you're stuck with 2 divided ends of colon, and you have to look at them and say, are they inflamed? Are they healthy? Do you smoke? Some other factors that would predispose you to developing what's called a leak, which is a hole in the anastomosis that we make, where you're leaking bacteria and stool out of that new connection, and that's a big problem, right? That's a huge problem, and we want to avoid that at all costs, because that requires multiple surgeries to fix. Probably a colostomy bag may or may not even be permanent at that point too. So we want to avoid that. And so that's when we talk about doing temporary ileostomy bags, and that protects and diverts the stool away for about 8 weeks. So not everybody needs one, but it is something I always talk to people about, and that's the determination is what's the extent of inflammation essentially.
What's something about colorectal health in general that you wish more people understood or even felt comfortable talking about? Because I know a lot of people still that can't help but giggle when they talk about stuff like this, right?
Everybody that comes into the office is always there like, oh, I'm sorry, this is so awkward. I wish we didn't have to talk about this. And I'm like, well, I saw 25 people today and had the same discussion 25 times. We just have to make it normal talking about poop and talking about stool bags and talking about hemorrhoids and fissures and all of these things that are very, very, very common.
Of course, right.
And nobody talks about them, right? And that's how I phrase it too when people come into clinic and I can tell they're a little nervous about it. It was like, hey, chances are you've got a friend that had this too, or at least know somebody that had a problem like this, and they just didn't talk about it at your dinner party.
Right.
So it is very common. People get very nervous talking about those things. You just have to make it normal or make it funny, crack jokes, whatever.
Well, and I would assume you would think that if the more conversations were had and it was much more common, people might take it more seriously at that point too. You'd be like, oh, well, I should go get it checked out. I should see a doctor about this and not just try to fight through the pain all the time.
Or hide through it. Or so many people, like you said, are nervous about, well, if I go into a surgeon, I'm going to get a colostomy bag.
Right.
People think that, and they come in, and that's like the first thing out of their mouth. They're like, before we say anything, they're like, "Am I going to get a colostomy bag?" And even if it does get to a point where we have to do that, it's almost always temporary.
Yeah.
Almost every colostomy can be reversed. That's not true for everybody, but almost always.
Well, and just imagine, like myself, how surprised you are when you wake up and you don't have one,
and you don't
right?
have
and it's
one,
a great day.
Especially when I scare you in the pre-op bay, like, you might come and wake up with a bag, and then
it's like the worst gift bag ever.
Sometimes I say it on purpose, then you wake up and you're like, wow, I didn't get it.
That's great. Well, Doctor, I really appreciate you coming in and talking more about this, because I do know probably more people than I would think I did that have this condition, and don't know where to turn or don't know what questions to ask. And just speaking from somebody that went through the whole procedure, start to finish, and having it for 2 decades, like you said, it's having more than one flare-up a couple times a year. I think you absolutely have to have that conversation with your doctor about maybe.
It's worth at least having a conversation.
Yeah.
You don't have to decide you want surgery, but at that point, you should have the conversation. I'll tell you the risks of surgery. I'll tell you the risks of not having surgery, and then it's your decision.
Right.
And not everybody goes for it, like you said, but at least then you know. At least then you know. And it can be in the back of your head. If I get another flare, well, maybe I'll go back there and talk to that guy who told me I might have a bag.
And honestly, it's not as bad as I thought it was going to be. I think because of the advances in surgery, the robots, the way that you guys at Monument handle it from start to finish. I mean, it couldn't have been from getting checked in with that first nurse, to leaving on that third day. Mm-hmm. It was handled so well. So to your team and everybody else, I can't be happier. Honestly,
appreciate that.
Yeah, absolutely, man. Yeah. Dr. Stephen Donahue, colorectal surgeon at Monument Health here in Rapid City. Thanks for taking time. I know you said that you probably do have a procedure yet this afternoon.
That's true.
That you're going to be doing. Okay,
Yep.
back at it.
Yep.
All right, thank you, doctor. I appreciate it.
Thank you.